Welcome back to the Deep Dive. We're here to break down complex topics into insights you can actually use. And today, we're tackling something that carries a lot of weight for many people. AMH, that's anti-Mullerian hormone. If you're exploring fertility treatments, especially IVF, you've probably heard about this number, maybe you've even gotten your result. And if that number came back low, well, it's easy to feel like your chances just plummeted. You might even think, is success even possible now? So our mission today is to cut through some of that anxiety. We're diving deep into why a low AMH number, while definitely important for planning treatment, is absolutely not the final word on whether you can succeed.
That's so true. We see it all the time, that immediate gut reaction when someone gets a low AMH result. It's a vital piece of the diagnostic puzzle for sure. But, the research and clinical practice consistently show it's really a starting point. It helps us tailor the approach, but it's not some kind of fertility fortune teller predicting failure. It's all about the context, your age, and finding the right protocol for that number.
Okay, great perspective to start with. So let's ground ourselves in the basics first. For anyone new to this, what exactly is AMH, and why do fertility specialists rely on it so much?
Okay, so simply put, AMH is a hormone. It's made by special cells called granulosa cells that surround the really small early stage follicles in your ovaries. Think of follicles as tiny sacs holding immature eggs. The more of these tiny resting follicles you have, generally, the higher your AMH level will be. So we see it as probably the most reliable indicator we have of your ovarian reserve. Basically, how many eggs might still be in the
Right,
ovaries.
the egg supply. And what makes it more reliable than, say, other hormone tests like FSH? I know those levels can jump around a bit.
Exactly. Its stability is its real advantage. Unlike FSH or estradiol, which change dramatically depending on the day of your menstrual cycle, AMH levels stay pretty consistent throughout the month. That means you can get tested on, day 5, day 15, day 25, doesn't really matter. And that consistency makes it super convenient, but also just a really dependable marker for doctors. Clinically, though, the main reason we use it, it's predictive. It gives the fertility team a good idea of how your ovaries might respond to the stimulation medications used in IVF.
Oh,
Knowing that helps them estimate how many eggs they might retrieve, and crucially, it helps figure out the right dosage of meds for you.
Ah, the dosage calculation. That makes sense.
Yeah.
If the reserve looks smaller, the plan needs to be different. Okay, let's get specific for our listeners who like the hard data. What are the typical AMH ranges we're talking about?
Yeah, definitely good to know the numbers, though units can vary a bit depending on the lab. Let's use nanograms per milliliter, NGML, which is common. So a normal to high fertility reserve is generally considered somewhere between 1.5 and 4.0 NGML. Now, where people start to get concerned, low AMH, indicating what's called diminished ovarian reserve, or DR, is typically defined as being below 1.0 NGML. That's about 7.1 pMello in other units.
Okay, below 1.0 is low. And what about the numbers that really trigger alarm bells?
That would be the very low AMH category. We're talking levels below zero point 0.5 NGML or roughly 3.6 pMol. Understandably, when someone sees a number like, say, zero point 0.3, their heart sinks. They might think, well, that's it then. And this is exactly where we need to talk about the huge difference between quantity and quality.
Yes, that feels like the absolute core of this discussion. You get that low AMH number, and the immediate thought is, I don't have enough eggs left.
Yeah.
Why is focusing only on that quantity aspect potentially misleading?
Because AMH tells us almost exclusively about quantity. Think of it like counting the number of apples left on the tree. It gives us an estimate of the potential number of eggs available. But, and this is the crucial part, AMH tells us absolutely nothing about the quality of those eggs. It doesn't measure their genetic health or their ability to develop into a healthy embryo.
Okay, that's the hopeful angle, especially for someone with a low number. Can you elaborate on that link, or lack thereof, between low AMH and egg quality?
Right. Egg quality is driven primarily by one main factor, and it's not your AMH level, it's your age. This is probably the most encouraging news for a younger woman, let's say someone under 35, who gets a low AMH result. Even though her quantity might be lower, the eggs she does have are statistically much more likely to be genetically normal and healthier compared to an older woman who might actually have a higher AMH number but whose eggs have aged more.
So a low AMH doesn't mean the few eggs you have are somehow bad. It just means the pool you're working with is smaller, which means the strategy has to shift, right? You can't magically make more eggs, so the focus becomes getting the absolute best out of the ones that are there. It sounds like it becomes a game of precision.
Precision is exactly the right word. Yeah, low AMH means realistically you probably won't retrieve a huge number of eggs in an IVF cycle. That's the challenge. But this is where a good fertility specialist really earns their stripes. They don't just use a standard one-size-fits-all protocol, they pivot.
How do they do that? What are the actual adjustments doctors make when they see that low AMH to try and maximize the chances with fewer eggs?
Well, there are a few main strategies. The first and maybe most common is adjusting the medication dosage. Since the ovaries seem less responsive based on the AMH, doctors might recommend higher doses of the stimulation drugs. Those are called gonadotropins, hormones like FSH and LH. The idea is to push the ovaries a bit harder to recruit and mature as many follicles as possible from that limited reserve in that particular cycle.
Okay, stimulating more intensely to try and get a few more eggs from a smaller starting pool. Makes sense.
But then, interestingly, the second strategy is often to go in the complete opposite direction, using much gentler protocols. These are things like mini IVF, which uses very low doses of medication, or even natural cycle IVF, which might use no stimulation drugs at all. With these approaches, the goal isn't to retrieve 10 or 15 eggs. It's maybe to get just 1 or 2 really good quality eggs that the body might select naturally that month. It's about optimizing for quality when quantity is limited, sometimes by reducing the stress on the ovaries. It's like quality over quantity in action.
It's really interesting how AMH guides the strategy in both directions. And we should probably quickly touch on the other side, too. What about people with very high AMH? That often comes up with PCOS, right?
Absolutely. That's a great point. Very high AMH often signals polycystic ovary syndrome, or at least a polycystic-like ovary structure. It predicts a potentially very strong response to stimulation meds, sometimes an overresponse, and that increases the risk of something called ovarian hyperstimulation syndrome, OHSS, which can be serious. So for those patients, doctors do the opposite. They intentionally use milder protocols and lower drug doses to keep things safe while still aiming for a good number of eggs. So yeah, AMH really is like the compass guiding the medication strategy, whether it needs to be ramped up or dialed way back.
Okay, so AMH is the starting point on the map, a key coordinate. But you can't navigate with just one coordinate, right? What other tests do specialists use to get the full picture of someone's fertility?
You're absolutely right. AMH is almost never looked at in a vacuum.
Right.
There are 2 other key pieces of information that provide really important context. The first one is the antral follicle count, or AFC.
AFC, okay. What does that tell us that AMH doesn't already cover?
So the AFC is done via ultrasound, usually early in the menstrual cycle. The doctor actually counts the small visible follicles, typically those between 2 and 10 millimeters that are present on the ovaries at that specific time. Think of it this way. AMH gives an idea of the overall long-term reserve, while the AFC provides a snapshot of how many follicles are potentially ready to respond to stimulation in this particular cycle. Using AMH and AFC together is pretty standard, and it really helps refine that prediction of response and the appropriate medication dosage.
Got it, like a long-range forecast versus the current weather report. And the other key test?
That's FSH, or follicle-stimulating hormone. This one is cycle-dependent. It's usually measured on day 3 of the cycle. High FSH levels often go hand in hand with low AMH. Basically, FSH is the hormone from your pituitary gland that tells your ovaries to get working and grow follicles. If your FSH level is high, it means your brain is having to shout louder, signaling that the ovaries are struggling to respond. So it's another indicator that the ovarian reserve might be low or less responsive. Putting all 3 together, AMH, AFC, and FSH gives a much more complete diagnostic picture than any single one alone.
Okay, that makes a lot of sense. Which brings us to the really practical part. We've established you can't really fix a low AMH number or turn back the clock on ovarian reserve. But since the focus shifts so heavily towards maximizing the quality of the eggs you do have, what kinds of things like supplements or lifestyle changes does the research suggest might actually help support egg quality?
Yeah, that's the proactive angle, right? Since quality is key, the focus turns to supporting the health of the egg cells themselves, especially their little energy factories, the mitochondria. Probably the most talked about supplement in this context is coenzyme Q10, or CoQ10. It's a powerful antioxidant. Egg quality can decline partly due to oxidative stress, which tends to increase with age. CoQ10 is thought to help combat that stress and maybe even boost mitochondrial function. The idea is to improve the egg's energy supply, which it needs for healthy division and development after fertilization.
So helping the egg have the best possible internal resources. What else often comes up?
Vitamin D deficiency is quite common and has been linked to poor fertility outcomes, so ensuring adequate levels is often recommended. Another one you hear about, particularly with low reserve, is DHEA, that's dehydroepiandrosterone. Some studies suggest it might improve ovarian function and response in women with DOR. But, and this is a big, but DHEA is a hormone precursor. It absolutely must be taken only under close medical supervision because it can have side effects and isn't right for everyone.
Okay, that's a critical distinction. CoQ10 and vitamin D are more general support, while DHEA is more like a medical intervention needing a doctor's guidance. What about lifestyle?
The foundational stuff really matters here. First, avoiding things that damage cells. That means stopping smoking, it's terrible for egg quality, and cutting back significantly on alcohol. Second, exercise. Finding that balance is key. Moderate, regular activity is generally beneficial for overall health and blood flow. But really excessive, intense training might actually stress the body and potentially divert resources away from reproduction. And the tough one, stress reduction. Chronic stress impacts hormones in ways that aren't helpful for fertility. Finding ways to manage stress, easier said than done, I know is important.
It really reframes the situation, doesn't it? Moving from feeling helpless about a low number to feeling empowered to take steps that support quality. So the deep dive seems clear. Low AMH is a really important piece of information. It helps doctors tailor your treatment plan, but it is absolutely not a guarantee of failure. With the right personalized approach, whether that's higher stimulation or a gentler method and that intense focus on egg quality, success is still very much on the table.
Exactly. And what's kind of empowering is, while you can't change your AMH number itself, that quantity predictor, the actions you can take today are all geared towards influencing the quality aspect of your reproductive health. That shift towards proactive steps is maybe the most powerful thing to take away.
That's a really positive and action-oriented thought to end on. Thank you so much for walking us through all this data and offering that hopeful perspective. Now, before we wrap up, we absolutely have to state clearly, everything we've discussed here on the Deep Dive today is for educational and informational purposes only. This is not professional medical advice. For any personalized evaluation, diagnosis, treatment plan, or specific medical guidance about your own situation, please always consult with your doctor or a qualified fertility specialist. And if you're looking for more comprehensive information and detailed guides covering the whole in vitro fertilization process, you can find excellent resources over at the portal ivf4me.com. That's pronounced IVF for me. We wish you all the very best on your journey.